today for our Paying for Cures Self-Insured Employers Workshop. It's a pleasure to host this session today. If you go to the next slide, I'll be your facilitator. I'm Jane Barlow. I'm a senior advisor to MIT's focus group, which sits in the Center for Biomedical Innovation. And I'm also Chief Clinical Officer at, we want to kick off with a poll. We'll have two polls should pop up. We'll start with the first one, which is really to just gain some insight from you around any significant changes you've made for 2021 health benefits based on current or anticipated cell and gene therapies. So you can see that the majority of folks have made no changes to 2021. So if we move to the second polling question, and that polling question is around the likelihood that you'll make changes to your 2022 health benefits based on current or anticipated cell and gene therapies. Okay. So we're going to circle back to this question at the end of the day. So I'm not going to show you the results right now. So let's move on to framing the issues. So by way of background, this Paying for Cures work comes out of a group at MIT called FOCUS, which is Financing and Reimbursement of Cures in the U.S. So this is a think and do tank that got started back in 2016, and it's dedicated to making sure that innovative cures are accessible and sustainable for all stakeholders, with the thought that to ensure that we continue to have innovation, patients need to have access. And so patients, payers, hospitals, developers, academics, policymakers are all part of this group, and we've had over 350 individuals involved from over 90 organizations over time. And really the questions that we've been dealing with is how to address each stakeholder's concerns to understand the challenges and the opportunity, and to flesh out new tools that will help us along the way to ensuring that there's sustainable access for patients. So if we go to the next slide, we talk about cell and gene therapies, but I want to make sure we level set so everyone knows what we mean by that. And fundamentally, gene and cell therapies involve a modification of genes. So this, graphic shows the replacement, essentially, of a defective gene with a healthy gene using a viral vector, where the healthy gene's inserted into the virus, and which the virus is harmless to the patient, and then administered to the patient, so the patient now has a healthy gene. So think about a patient with hemophilia who has a defective gene. You now give them the healthy gene, so they're able to manufacture their own factor. So gene therapy can be used to replace a gene that's causing a problem, to add genes to help to fight disease or to treat disease, and to turn off genes that are causing problems. Cell therapy doesn't use a viral vector. It's modifying the patient's cells or a donor's cells. In the case of the CAR T therapies, the T cells, so that they go out and address the cancer. And that would be a way of adding genes or modifying genes in the body to fight a disease. So if you go to the next slide, we've had multiple treatments that have been approved since 2016. The majority of those, the 5 to the left of the slide are gene therapies for various diseases. And to the right, Lexterna and Zolgensma are actually cell therapies. So I think you all know what distinguishes these therapies is, one, they're a one-time treatment, generally associated with high costs. And the second is they're durable and potentially curative for some patients. So if we go to the next slide, there's some challenges that creates. And one of the challenges is that the timing of the payments is front-loaded. I'm not seeing the actual graph. There we go. Thank you. So if you look at durable therapies, you have that one-time therapy, and that benefit accrues over time. Whereas in classic medications, as a payer, you're paying, period to period, and you get benefit period to period. If a patient moves to another health plan or another employer, that benefit you no longer pay, and you no longer get the benefit. Whereas in the durable therapy, you've really paid all the costs up front, but you no longer see that benefit. So there's this this payment timing risk because of the costs being all front-loaded. There's also an actuarial risk that may be of concern, particularly if you're a smaller employer, and the smaller you are, the harder it is to actually predict the likelihood of encountering a case in your plan, particularly for some of the genetic diseases that don't have ready treatments. You may not have a way to identify folks even in your claims data. So then the other issue that it has been a concern is that these drugs are meant to have durability over a long time, but haven't been studied necessarily in large groups of patients for long periods of time. So there's some risk in terms of whether this will work in an individual patient and for how long it will work. So it's meant to be durable and may be curative, but we don't know how long that will last. And then I've mentioned this issue around mobility, which is a challenge as you pay for patients who then may move out of your plan. So we're going to come back to these risks in some of our next sessions, but I wanted to lay them out here up front because they're foundational to the challenges that durable therapies create. So if we go to the next slide, MIT has studied and surveyed, talked to payers as part of our stakeholder group for really since the beginning of this. We launched a formal survey in 2017, and we did another survey in 2018 that went into 2019. That was a broad survey across many payers. So we invited over 400 health plan and employer payers and leaders, and with the goal of identifying what the current and future management plans were for high-cost, durable one-time therapies. So if you go to the next slide, we got responses from payers that represented over 280 million lives. So great participation across multiple sectors of the industry. So we had commercial fully insured payers, Medicaid, Medicare Advantage, and you see that we had 10 self-insured employers participate in this that all told covered over 900,000 lives. We'd like to have had more self-insured employers, but that's what we got at that time. So if you go to the next slide, one of the questions we asked the payers And again, remember this is the end of 2018 into 2019. We asked what the level of concern was regarding the financial risk and impact of high-cost durable therapies. And, this slide divides those responses by the segment. And you can see that commercially fully insured payers had the highest levels of concern. Overall, everybody had concern, but self-insured employers had less concern relative to the other segments. And frankly, we weren't exactly sure why, but it was one of the concerns that we had over time was whether the self-insured employer group had enough knowledge and education around this area that they were able to address concerns for their plan. So we can have continued to follow the segment, and you'll see some other examples of the survey as we go through the day. But in part, one of the reasons why we wanted to have a session today was to ensure that self-insured employers had a resource specific to them and education specific to them around understanding the issues that may be associated with cell and gene therapy coverage and reimbursement. So we'll pause now and take another polling question. And what we'd like to know is how many patients in your health plan have actually been treated with one of these approved cell and gene therapies? Okay, it looks like our responses are pretty much in. And so you can see we have a breakdown here. It looks like close to half of people don't know whether patients have been covered or not. And that those that have covered ranges from the majority have had no patients, which is not unexpected, to some that have had more than 10 patients treated. I expect that's probably a larger plan. Okay, great.